Now coming to the most important point, your goals of management. There are only two goals. First is to identify and treat the cause, and goal 2 is support the patient. Now coming to identifying and treating the cause. Here you have to locate the source of bleeding, and once you located it, you have to control it. Now if you have the bleeding in thoracic cavity, here there will be history of chest trauma. When you auscultate, there will be diminished breath sound on that side, and there will be desaturation and oxygen requirement will be increased. You do a chest X-ray or a CT thorax to know whether patient has pneumothorax or hemothorax. You place the chest tube on the affected side. If the chest tube shows greater than 1 liter of blood on that side, you have to shift to the operating room for thoracotomy. Now coming to abdominal cavity. Here there will be an history of abdominal trauma and patient will have a distended abdomen. If you do a direct peritoneal lavage, there will be gross blood which is greater than 10 power 5 of RBC. You do a fast scan, locate for free fluid in the peritoneal cavity, shift to operating room for explorative laparotomy. Now coming to pelvis or retroperitoneum. Here there will be a history of abdominal or pelvic trauma, flank ecchymosis, unstable pelvis and hematuria will be there. You do a direct peritoneal lavage to rule out intra-abdominal bleed. Also do a pelvic X-ray. Wrap the sheet around pelvis and do a pelvic angiography. Look for blush or extravasation and go for angioembolization. Coming to external bleeding. Here you should check the blood on floor whether it is coming from the head or scalp or from the extremity. If the scalp pet, try to control it with the nylon suture. If it is an extremity bleed, go for a pressure and elevation. If still bleeding is not controlled, place a tourniquet proximal to the injury which is set at a higher pressure than the systolic blood pressure. Now coming to long bone injury. Here there is deformed extremity, cush injury or mangled extremity. The estimated blood loss with femur is around 750 ml to 1 liter. In tibia, it is between 500 to 750. Here, you have to go for immobilization and minimal manipulation of the injured extremity. Don't forget to look for compartment syndrome here. Now coming to goal 2. Here, the first priority is to establish IV access and go for fluid resuscitation. Whenever you talk about fluid resuscitation, anesthesiologists should have a good understanding because they infuse the maximum number of intravenous fluid. You have different fluids like crystalloids, colloids, hyperoncotic solution, and different people where the percentage of water in the human body differs as they get older, and you have different type of surgery where the blood loss will be different. Apart from that, the patient is going to be in hemorrhagic shock which can alter your hemodynamics. There is multi-organ dysfunction, inflammation, disturbed hemostasis which can cause more bleeding, altered endothelium, ARDS which causes hypoxia, and most importantly there is volume deficit. So you have to manage the fluid, patient as well as the surgery in addition to hemorrhagic shock. You have to match everything and come with an ideal solution. Come with the solution, you have to understand certain physiological terms which is related to fluid. First is the tonicity. The normal plasma osmolarity is around 200 milliosmoles per kilogram. Whenever you have a fluid which is closer to this is called isoosmolar. Your 0.9% normal saline and ringer lactate and 5% dextrose has osmolarity similar to plasma and they are called as isoosmolar. Hyperosmolar is more than 300 osmolarity. Here you can see that dextrose containing fluid, 10% dextrose or 0.45% normal saline in dextrose, they are all hyperosmolar. But what happens when they go into the intravascular compartment? Here in isoosmolar, like your 0.9% normal saline and ringer lactate, even when it goes into the intravascular compartment, the tonicity is maintained, the osmolarity is maintained, so it is called isotonic. But the dextrose containing fluid, whenever it enters into the vascular compartment, they get metabolized, and what was hyperosmolar outside the body, when it enters into the intravascular compartment, as the dextrose is metabolized, they become hypotonic. This understanding you should have when you administer dextrose containing fluid. And whenever you give a hypertonic solution, here what happens is, the tonicity of the solution which you infuse into the intravascular compartment is higher. So this tonicity draws the fluid from the intracellular compartment and there will be intracellular dehydration. If you give an isotonic solution, the isotonic is same that of plasma. So there won't be net movement of fluid outside the cell. The intravascular and the intracellular compartment, the fluid balance is maintained if you give isotonic solution. But if you give hypotonic, fluid which you give migrates into the intracellular compartment and cause intracellular swelling. So you have to understand that hypertonic solution causes cellular dehydration, isotonic doesn't cause much disturbance, and hypotonic causes cellular swelling.